Now the last is our SIP, hardly 5 minutes will take. The induction of labor at term in older mothers. Okay, so this is a scientific impact paper number 34. It is published in February 2013. Okay, so this particular table gives you the stillbirth rate and neonatal death. Okay, so at different age group, what is the stillbirth rate? Okay, so between 25 to 29 weeks, 29 age, it is a 4.6. Okay, and it is almost same here, but if you see more than 40, it is almost double, 7.6. Okay, so this particular you can remember here in this particular table. Okay, the next table again shows absolute risk of stillbirth in women of advanced maternal age, what they called as AMA, advanced maternal age, between 37 and 41 weeks of gestation. So here it is a weeks of gestation, and here it is a years. Okay, so less than 35 years, 35 to 39 years, and more than 40 years. Okay, so considered, because elderly mothers, it is more than 40 years, it is 1 in 1064 at 37 weeks of gestation, or before 38 weeks of gestation. Between 39 to 40, it is 1 in 500, and after 41 weeks or 41 weeks of gestation, after 40 years, it is 1 in 400. Okay, so 400, 600, 1000. You can remember this way. Generally, these they may ask you more than 40 years. So what is the background and introduction? The average age of childbirth is rising significantly across Western countries. In the UK, maternities, women aged more than 35 years increased from 8% to 20%. Maternities in women more than 40 years rose from 1.2 to 3.6%. These figures will not be asked. Okay, advanced maternal age is associated with higher risk of placental abruption, placenta previa, malpresentation, low birth weight, preterm and postterm delivery, postpartum hemorrhage. Increased use of ART raises the risk further due to higher chance of multiple pregnancy, and pre-existing conditions like hypertension, diabetes, obesity become more common with these. That is why these patients are at a higher risk. Okay, we will have another lecture on membranes. Okay, so that about the maternal mortality, they have got a separate guideline for and what care should be taken with the patients who are elderly. Okay, they have specifically given certain guidelines. Even after adjusting for comorbidities, remember, so these patients, we have just seen, these patients are at risk of all these things, especially these patients can have a pre-existing comorbidity. But even if you adjust statistically adjust these comorbidities, then also advanced maternal age independently increases the risk of antepartum and intrapartum stillbirth. Neonatal mortality is also increased. And epidemiological evidence, what does the epidemiological evidence says? That women who are more than 40 years, their risk of stillbirth at 39 is same as young patients stillbirth risk at 41 weeks. So young patients stillbirth risk at 41 is these people will have at 39 weeks of gestation. Okay, so inducing the labor earlier in older women could be justified. That is why this scientific impact paper says inducing labor earlier in older women could be justified, but must be weighed against the potential increase in the emergency cesarean sections and the neonatal risk. Okay, now what is the risk of stillbirth in older mothers? Unexplained stillbirth rise with both maternal age and gestational age in nulliparas and multiparas. Lower cumulative risk of parental death occurs at 38 weeks. Okay, so at 41 weeks, stillbirth risk below 35 years, it is 0.75 per 1000. After 40 years, it is 2.5 per 1000. Okay, this is actually USA study. Effect remains after adjusting for medical disease, parity, race, and ethnicity. And there are ethnic disparities. Afro-Caribbean women will have 2 times higher stillbirth risk compared to Caucasian and Asian women. Nulliparous women more than 40 years have a higher risk of intrapartum stillbirth due to intrapartum anoxia. That is why these particular women who are more than 40 years of age, induction of labor can be considered at around 39 weeks of gestation. Then what is the etiology of stillbirth in older mothers? Exactly not known, but what they have found, FGR increases with maternal age. Adjusted odds ratio for FGR is around for 35 to 39 years 1.4, and here it is 3.2, so almost double. But again, these figures will not be asked. You just remember FGR is increases with the maternal age. Okay. However, FGR is not more common in stillborn babies of older mothers compared to younger ones. Routine FGR or Doppler for all older mothers is not currently supported evidence. Okay. Coming to the neonatal mortality. Neonatal mortality is higher in mothers less than 25 and more than 40 years. In UK, women more than 40 years are 1.3 times more likely to have a neonatal death than those aged between 25 to 29. This is the safer age group. Okay. Absolute risk of neonatal death as per the table 1, which is given in the SIPs, it is 1 in 345 for this age group, and for more than 40, it is 1 in 263. That is the absolute risk of neonatal death. Okay. Coming to the intrapartum complications in these elderly patients, aging impairs the myometrial function, increases the risk of labor complications. So older mothers will have a higher risk of instrumental delivery, cesarean section for dystocia, prolonged labor. Risk increases linearly with age and especially in nulliparous women. Adjusted odds ratio per 5 years of age will increase for instrumental delivery 1.49, intrapartum cesarean section again 1.49, and in nulliparous women more than 35 years, prolonged labor more than 12 hours, and surgical intervention due to dystocia is increased almost by 33%. Okay. Older women are more likely to need oxytocin augmentation and higher doses and longer duration of oxytocin for vaginal delivery success. Okay. So high chance of that they will require augmentation. Now, will induction of labor at term will improve the outcome? This is what is the question in this paper they have answered. So what is the current practice and perception? Induction at term is widely practiced to reduce the late stillbirth risk in older mothers. What does the survey data say? 37% of obstetricians offer induction at term to women between aged between 40 and 44. 55% will offer to the women aged more than 45 years. Elective cesarean section rates are rising with age, often due to lower threshold among patients and providers. Again, these figures are not important from the SBA point of view. What are the cesarean section consideration? NICE recommends shared decision making regarding cesarean and versus vaginal birth. Planned cesarean before 39 weeks will have a high risk of neonatal respiratory issues and NICU admission. Emergency cesareans will carry higher risk than vaginal birth. Vaginal birth after induction remains common in older nulliparous women. Okay. So induction versus expectant management. Induction at or after 41 weeks improves the perinatal outcomes without raising the cesarean section rates. This is as per the Cochrane review. NICE recommends induction beyond 41 weeks to prevent post-maturity stillbirth. Evidence shows induction from 37 weeks can improve the outcome without increasing the cesarean sections. So, but what the data says on the older mothers, there is a limited data specifically for older women. So when the UK data is applied, inducing all women who are more than 40 years at 39 weeks instead of 41 weeks, 17 stillbirth will be prevented. So, and what will be NNT, that is number needed to treat, is high, 9,340 inductions. If the induction is carried out at 40 weeks, you will prevent 7 stillbirth, but the number needed to treat will be 4,750. Okay. So what is the final opinion and recommendation from this SIP? Stillbirth risk at 39 to 40 weeks for more than 40 years is 2 per 1,000. For less than 35 years, it is 1 per 1,000. Since women who are more than 40 years at 39 weeks have a similar risk as younger women at 41 weeks, induction may be justified earlier. This we have seen what exactly they want to see, say that for young reproductive age group patients, whatever is the risk at 41 weeks, these women will have at 39 weeks, and that is why the induction is justified. Okay. Stronger case for induction if she is nulliparous, comorbidities are present, Afro-Caribbean ethnicity, unclear impact on surgical delivery and neonatal mortality, specifically in older women. Evidence overall suggests no increase in cesarean section or instrumental deliveries with induction. Okay, so these are the certain messages from this scientific impact paper. Elective cesarean section may still be preferred by some older or nulliparous women, and the risk is to benefit discussion is essential in these cases. Okay, so this is what is the final opinion recommendation we can remember. So that finishes today's last topic of induction in older women. Thank you.